the active form of angiotensin, and it is a potent vasoconstrictor. Angiotensin 2 increases blood pressure by vasoconstriction. Angiotensin converting enzyme inhibitors block the conversions of an angiotensin 2 by inhibiting the enzyme's angiotensin converting enzyme, resulting in decreased concentration of active angiotensin 2. Due to the unavailability of angiotensin 2, instead of vasoconstriction, vasodilation occurs. The angiotensin converting enzyme inhibitors lowers blood pressure by blocking the conversion of angiotensin 1 to angiotensin 2. Regulatory enzymes. Enzyme activity can be regulated by two mechanisms: regulation of enzyme by non-covalent modification. These enzymes are also called allosteric enzymes, and regulatory regulation of enzyme by covalent modification. Regulation of enzyme by non-covalent modification, allosteric enzymes. These enzymes have two or more subunits. In addition to the active site for their respective substrate, they also possess a special site called allosteric site. On these allosteric sites, regions called effectors can get bound through non-covalent bond. The non-covalent bonding of effectors may result in either an inhibition or activation of the enzyme activity. Allosteric inhibitions can be inhibitors. Enzymes can be inhibited when an effector called negative effector or an allosteric inhibitors combines with the allosteric site of the enzyme. Feedback inhibition of enzymes. Allosteric inhibition enzymes can be inhibited by the product of its own catalytic product. Products in excess, inhibition of the enzyme activity, decreased product. Allosteric activation. Enzymes can be activated when an effector called positive effector or an allosteric activator combines with the allosteric site of the enzyme. Feedback in activations of enzymes. Allosteric enzyme can be activated by the products of its own catalytic product. Decreased products, activation of enzyme activity, increased synthesis of the product. Regulations of enzymes by covalent modification. Enzymes can be regulated by covalent modification. Regulation is most frequently done by the addition of or removal of phosphate group from specific serine, threonine, or tyrosine residues of enzymes. Addition of phosphorylation is catalyzed by a by a family of enzymes called protein kinase, hexokinase, phosphofructokinase. For example, in glycolysis, these enzymes utilize ATP as phosphate donor. Removal of phosphate dephosphorylations from phosphorylated enzyme is catalyzed by a family of enzymes called phosphoproteins, phosphatases, glucose 6-phosphate phosphatase, for example, in gluconeogenesis. Addition or removal of the phosphate group to and from an enzyme will result either in activation or inhibition of the enzymes. Enzymes in clinical diagnostic. Determination of certain serum enzymes level in the blood is of great help in the diagnosis of certain diseases. Amylase is raised in parotitis and acute pancreatitis. Lipase is raised in acute pancreatitis. Cholinesterase is decreased in liver diseases and increased in nephrotic syndrome. Alkaline phosphatase is increased in hyperparathyroidism, obstructive jaundice, and rickets. SGPT or ELT is raised liver is diagnostic for acute liver disease. SGOT-EST is uh, raised level is diagnostic for acute liver damage and is also seen but not diagnostic in acute myocardial infarctions. CPK raised level is diagnostic for acute myocardial infarctions, also increases in many diseases of the muscles. LDH raised level is diagnostic for acute MI, also increases in acute liver damage. GGT is diagnostic for alcoholic liver disease. It also increases in hepatobiliary obstructions. Phosphatase is raised in prostate carcinoma with metastasis, but it is not diagnostic. It is used as screening patients with suspected prostate cancer. Cardiac enzyme CPKMB is released by infarct myocardial peaks within 24 hours and usually falls back to normal before 48 hours. SGOT-EST peaks at 24 to 48 hours and may fall back to normal by 72 hours. LDH1 peaks at 3 to 4 days and remain elevated for 10 to 14 days. Nowadays, these enzymes are not used primarily for the diagnosis of myocardial functions. Now, troponin TRI are used as first line of investigation for the diagnosis of MI. Enzyme deficiencies, it glucose 6 phosphate dehydrogenase deficiency, dehydrogenase of HMP short, pyruvate kinase of glycolysis, and glutathione reductase. Some of the enzymes are used as medicine. Enzymes can be used for therapeutic purposes in the form of ointment, injectables, and edibles. For digestive disorders, lipases, proteinases, and amylases. Pancreatine and pepsin enzymes or pancreatic juice are used alone or along with dry bile powder. For blood coagulation, urokinase and streptokinase are used for the lysis of blood clots. Thrombin for the formation of clot to stop bleeding, to increase blood supply to the tissues. Kallikrein is used for the impairment of blood supply to the tissues, extremities, and the heart. In animals, hyaluronidase causes loosening of the deeper layers of the skin, resulting in increased absorption of ointment in the treatment of sprain, hematoma, and thrombophlebitis. Trypsin and chymotrypsin for the degradation of necrotic tissues, masses of pus and fear. They also cause cleaning of the wounds and promote wound healing. Cancer treatment. L-asparagine for the treatment of lymphoblastic leukemia, especially in children. Now, I will discuss the vitamins. Vitamins are organic compounds required by the body in trace amounts to perform specific cellular functions. Human body cannot synthesize vitamins except vitamin D, K, and some of the vitamins are B complex, and therefore they must be supplied in the diet. Classification. Vitamins are classified into two main groups, fat soluble and water soluble. Fat soluble include vitamin A, D, and E and K. Only vitamin K has a coenzyme activity. These vitamins are released, absorbed, and transported along with the fat of the diet. They are not readily excreted in urine. They are stored in significant amount in liver and adipose tissues. Vitamin A. Animal sources: liver, kidneys, cream, egg yolk, fish, colostrum is also very rich in vitamin A. Plant sources: carotenes. Carotenes are yellow-red pigment found especially in carrots, yellow corn, sweet potatoes, peaches, and spinach. They are antioxidant. Among carotene, beta oxidation are the most efficient precursors of vitamin A. Carotenes do not have any vitamin A activity. They are converted to active vitamin A under the influence of thyroxine. Some thyroxine is required for the conversion of carotenes to vitamin A. In thyroxine deficiency hypothyroidism, carotene accumulates in the blood, resulting in a condition known as carotenemia. Beside hypothyroidism, conversion of carotene to active vitamin A is also decreased in diabetes mellitus. Absorptions and transport of vitamin A from intestine to the liver. Retinol esters present in the diet are hydrolyzed to free fatty acids and retinol, vitamin A. Carotene in blood diet are cleaved and reduced to retinol. In the intestinal mucosa, retinol is re-esterified to long chain fatty acids. Now, vitamins. Water soluble. These are the ascorbic acid and vitamin B complex. Energy releasing thiamine, riboflavin, niacin, biotin, pantothenic acid. Hematopoietic, folic acid, cyanocobalamin, others, pyridoxine, pyridoxal, and pyridoxamines. The esterifies vitamin A. This esterified vitamin A is absorbed by the intestine and released into the lymphatic as a component of chylomicron. Retinol and esters present in the chylomicron are taken up and stored in the liver. From liver to the target cells, when body needs, liver releases retinol. Retinol attaches to the plasma retinol binding protein. This retinol binding protein complex is transported to the extrahepatic tissues. Retinol RBP complex reaches to the specific receptors on the surface of the target cells. The complex breaks up and retinol enters into the cell. Inside the cell, retinol binds with cellular RBP. Inside the cell, retinol binds with cellular RBP. This cellular retinol RBP complex is carried to the sites in the nucleus where the vitamins act in a manner analogous to steroid hormones. Functions of vitamin A. Vitamin A performs various functions, for example, maintenance of visual cycles and epithelial cells, reproductions, growth, metabolic role, and prevention of chronic diseases. Retinol, the aldehyde form of retinol, performs all the functions of vitamin A. Retinoic acid, the oxidized form of retinol, they perform the functions of growth and maintenance of epithelial tissues. Visual cycle. Vitamin A is a component of visual pigment rhodopsin, the commonly known as visual purple of rods and cone cells of retina. Rhodopsin consists of 11 cis retinol, specifically bound to the protein opsin. Rhodopsin is essential for vision in dim light when eyes are exposed to bright light. All of the rhodopsin gets hydrolyzed, and when the person comes back in the dark room, he will be unable to see in the dark for a while. In the dark room or dim light, resynthesis of rhodopsin takes place, and after some time, the person begins to see in the dim light. The time required for resynthesis of rhodopsin depends upon the intensity of light thrown in eyes and the availability of vitamin A. If vitamin A is deficient, the synthesis of rhodopsin cannot take place, and the person becomes unable to see in the dim light. Night blindness. Dim light, cis retinol, retinol, all trans retinol in bright light converted to all trans retinol, and it enters into the blood. And all trans retinol is converted into 11 cis retinol. This is the isomerization, and it is oxidized to 11 cis retinol, that is in the dim light. And 11 cis retinol is converted to rhodopsin, and it is in the bright light, it is all trans retinol. Reproductions. Retinol and retinol both are essential for normal reproduction. They support spermatogenesis in males, prevent fetal loss in females. Retinoic acid is inactive in maintaining normal reproduction and visual cycle. Animals given vitamin A only as retinoic acid uh, from birth will be blind and sterile. Growth. Vitamin A is essential for the normal growth of bones. Animals deprived of vitamin A initially lose their appetite, possibly because of keratinization of the taste buds. Bone growth is slow and fails to keep pace with the growth of the nervous system, leading to CNS damage. Maintenance of epithelial tissues. Vitamin A is essential for the normal differentiation of epithelial tissues and mucus secretion. In its deficiency, the normal epithelium is replaced by a stratified, dry, and keratinized epithelium, which results in some of the clinical conditions: ophthalmic disorders, genitourinary disorders, pulmonary disorders, dermatological disorders, and defective dentite. Metabolic role of vitamin A. Vitamin A helps in the synthesis of glucocorticoids. It also helps in the synthesis of glycogen from its precursors such as lactate and glycerol. It is required for the normal function activity of mitochondria, and excess or a deficiency of vitamin A interferes with oxidative phosphorylation (ATP) production. Prevention of chronic diseases. Population consuming diet high in beta carotene shows a decreased incidence of cardiac diseases, lungs and skin cancers, and reduced risk of cataract and macular degeneration. The protective functions of beta carotene may be due to the antioxidant properties or to other actions such as enhancement of immune system. Unlike vitamin A, beta carotenes are not toxic even at high doses for extended period. Toxicity: acute, severe headache, generalized weakness, dizziness and nausea, chronic fatigue, sleep disturbances, lack of appetite, peeling of skin, itching, loss of hair, cracked lips, hepatomegaly, splenomegaly, painful limbs and joints. Treatment: hypervitaminosis A. Hypervitaminosis disappears spontaneously on stopping vitamin A ingestion. Clinical notes are vitamin A deficiency. Many of the clinical disorders of vitamin A deficiencies are because of the keratinization of the normal epithelium throughout the body. Ophthalmic disorders, night blindness. One of the earliest signs the person will be unable to see in the dim light. Prolonged deficiency leads to an irreversible loss of visual cells. Xerophthalmia. It is a pathological dryness of the conjunctiva and cornea. Untreated xerophthalmia results in corneal ulcerations. Prolonged xerophthalmia results in blindness due to the formation of opaque caused by toad spots. Keratomalacia. Keratomalacia occurs in the first year of life. Cornea becomes dull and insensitive. Prolonged deficiency of vitamin A cause necrosis of cornea. Necrosed cornea may melt away within a matter of hours, resulting in permanent loss of vision. Genitourinary disorders. Kidney stones may result due to accumulation of stone-forming compounds normally present in urine around shed keratinized epithelium. Pulmonary disorders. Cilia of the respiratory tract are lost, resulting in highest rates of chest infection. Dermatological disorders. Since vitamin A is required for healthy epithelium, its deficiency causes dry skin, xerosis, scaling of skin, and forms small pustules around hair follicles. Acute and psoriasis are acne and psoriasis are effectively treated with retinoic acid and its derivatives. Retinoic acid used in the treatment of acne. Retinoic acid is tetra, teratogenic, therefore it is contraindicated in pregnancy. Defective dentine. Functions of tooth enamel will be defective and this may lead to dental caries. Vitamin D, cholecalciferol. They are group of sterol that have hormone-like functions. Sources: ergocalciferol, vitamin D2 found in plants, and cholecalciferol, vitamin D3 found in animal source tissues are the sources of pre-formed vitamin D. Best sources are cod and other fish liver oils. Human milk is poor in vitamin D than cow's milk. Endogenous vitamin D precursors. Dehydro 7-dehydrocholesterol is an intermediate product in cholesterol synthesis and is present under the dermis and epidermis of the human skin. When skin is exposed to sunlight, this 7-dehydrocholesterol is converted to cholesterol, cholecalciferol in the dermis and epidermis. Absorption, storage, and excretion. Vitamin D is absorbed along with fat of the diet. Bile salts are required for the digestion and absorption of vitamin D. It first appears in lymph as a component of chylomicron. It is stored in fat of the body. It is carried in the plasma in combination with a carrier protein called vitamin D carrier protein. It is mainly excreted in the bile. Activation of vitamin D. Vitamin D from diet and vitamin D3 under the skin are not physiologically active but are converted to active form by two sequential hydroxylation reactions. First hydroxylation occurs in the liver, vitamin D2 or vitamin D3. In presence of hydroxylase, oxalase is converted to 25-hydroxycholecalciferol. The product 25-hydroxycholecalciferol is also inactive, but it is the predominant and major storage form in the plasma. Second hydroxylation occurs in the kidney. 25-hydroxycholecalciferol is converted to 125-dihydroxycholecalciferol in presence of hydroxylase. 125-dihydroxycholecalciferol is the active form of vitamin D. Mechanism of action. The active molecule 125-dihydroxycholecalciferol binds to intracellular receptor proteins. 125-dihydroxycholecalciferol receptor complex interacts with DNA in the nucleus of target cells and either selectively stimulate gene expression and specifically repress gene transcription, resulting in protein synthesis. The most predominant action of 125-dihydroxycholecalciferol is to regulate plasma calcium levels. Functions of vitamin D. The overall function of 125 dihydroxycholecalciferol is to maintain plasma calcium levels. It does that in the following ways: increase intake of calcium by the intestine, minimizes loss of calcium by the kidney, stimulate resorption of bone when necessary. Effects of vitamin D on the intestine. 125 dihydroxycholecalciferol stimulates the intestinal absorption of calcium and phosphate. 125 dihydroxycalciferol enters the intestinal cells and binds to cytosolic receptor. 125 dihydroxycholecalciferol D3 receptor complex then moves to the nucleus where it selectively interacts with the cellular DNA and forms specific calcium binding proteins. Calcium binding protein causes the absorption of calcium from the intestine. In this way, the mechanism of action of what 125 dihydroxycalciferol is typical of steroid hormone. Effects of vitamin D on the kidney. These are of minor importance. Vitamin D minimizes the loss of calcium from the kidney. Effects of vitamin D on the bones. 125 dihydroxycholecalciferol stimulates the mobilization of calcium and phosphate from bones by a process that requires protein synthesis and presence of parathyroid hormones. Parathyroid hormones. Functions of parathyroid hormones. It acts directly to bones and mobilizes calcium from it to increase plasma calcium level. Parathyroid hormone has phosphate uric action. It increases phosphate excretion in urine by preventing its reabsorption from the proximal tubules. Parathyroid hormone increases reabsorption of calcium in the distal tubules. Parathyroid hormones increases the formation of 125 dihydroxycholecalciferol, which in turn increases calcium absorption from the intestine. Mechanism of action of parathyroid hormone. Ionized calciums are acts directly on the parathyroid gland in a feedback fashion to regulate the secretion of parathyroid hormone. Decreased calcium level increases parathyroid secretion, mobilization of calcium from the bones. Increased calcium level, inhibition of parathyroid secretions. Increased calcium level, inhibition of parathyroid secretions, deposition of calcium in the bones. 125 dihydroxycholecalciferol acts directly on the parathyroid gland to decrease parathyroid hormone messenger RNA. Increased plasma phosphate stimulates parathyroid hormone secretion by lowering calcium levels and by inhibiting the formation of 125 dihydroxycholecalciferol. Why it is important to maintain the plasma calcium level? To prevent hypocalcemic tetany, and for proper blood clotting. It is the first free ionized calcium in the body fluids that is a vital second messenger and is necessary for blood coagulations, muscle contractions, and nerve function. Decrease in extracellular calcium, inhibition of the nerve transmissions at the myoneural junctions. This effect is overbalanced by the existing uh, excitatory effect of the low calcium level on the nerve and muscle cells. The resulting condition is called hypocalcemic tightening, which is due to increased activity of motor nerve fibers. Thank you very much.